We frequently get asked by our members how they can access a clinical trial and where are clinical trials. We've tried to get the information for them. Cancer Research UK give locations, like they will say London, but they don't actually list the places, the hospitals, the trusts that offer trials for CLL. Is there any way we can get such a list?
Yeah, that's a very important question, isn't it? It's a shame that we can't get better information. There are some decent websites, aren't there, like clinicaltrials.gov, but I think that's mainly American-based. National trials like FLAIR, they're open in most hospitals, so those are big national trials. They're very successful, but of course then you also get these investigator-led studies which are much smaller, maybe 3 or 4 centres, and I think that's where it's more difficult to find out where they are. Many of those are sponsored by Bloodwise, so maybe we should talk to them and see if there's a better way of doing that. But yeah, no, it is often a case of knowing what your consultant knows is going on around the country, which is not adequate, is it, to be honest? I've got a few questions here, so shall I just work through these? Watch and wait, can anticoagulant therapy affect platelets? No, not really. You know, watch and wait, platelets count is a big factor in determining treatment response, usually because the CLL has suppressed the platelet count in the bone marrow. But you know, if you're on platelets or even warfarin, that doesn't matter. But obviously, we'd need to adjust that therapy if your platelets started to go down, because you would be at risk of bleeding. The other thing I didn't talk about today was, of course, CLL is associated with autoimmune problems. So where your body's immune system attacks your blood, attacks your red cells and attacks your platelets. So some patients can get low platelets because their immune system has started to attack them. That's a different problem, and we have to dampen the inflammation with steroids. But that's a thing that sometimes we come across. Yeah, I thought this would come up when I mentioned this. Should I get children tested if a father or grandfather has, well, CLL or multiple myeloma? Question says multiple myeloma. I think the answer to that is no, because myeloma doesn't have the genetic risk so much as CLL.
I think we've got one question at the back as
well. Okay.
Hello, Paul.
Hello.
Hi. Yeah, I just wanted to ask, and you may not be able to answer that at the moment, but getting back to this possible decision to take away funding for the drug for people, you know. Yeah. On a personal level, I've been on Ibrutinib for 4 years and I'm doing very well on it. If, you know, hopefully it doesn't happen, but if it does happen, would patients like myself then be offered something like venetoclax, or would they have to go back on chemotherapy? Because I assume that would be a cheaper option, as Ibrutinib is so expensive, and I guess it's all down to money.
Yeah, no, it's a very fair question. Things are moving very quickly on this issue, aren't they? And I was interested to hear what you talked about 1 hour ago, and the associations had an incredibly quick and effective response. I don't really know enough details yet of what's being heard through the Times. I can't believe that they would stop patients already on therapy. I would imagine it's new patients going on to therapy. So anyone on, I think you're pretty safe. I would imagine it's about saving money. I mean, the only thing just to bear in mind is that in the CLL guidelines that are being drawn up, it is considered that patients who have a long remission after chemotherapy could be considered for further chemotherapy. So we mustn't run away with the idea that it's absolutely inappropriate in any circumstance. That's quite interesting. And of course, you know, again, the argument in favour of that, I'm not talking in monetary value, is that if you keep more therapies for later down the line, then you may have a longer natural history in the end. So, you know, even the guidelines are suggesting that 2 forms of chemotherapy, maybe FCR, then maybe BR 4 or 5 years later, could be considered. So, but I mean, I'm a great fan of Ibrutinib and I've used it a lot over many years. And, you know, that's what I would prefer, obviously. With the proviso is that we've only got 6 years data now, and so I don't quite know how Ibrutinib is going to play out in the long term. But I think it's a very rapidly moving political field, and from what you said an hour ago, I'm hopeful that perhaps we'll get the decision we want.
I'm the Reverend Elizabeth Nichols, and I was first diagnosed nearly 20 years ago. At the end of this year it would be. And I had chlorambucil and then fludarabine then, and I was in remission for 14 years.
Yeah.
So I started back on treatment and I went on FCR. I had 2 rounds which made me incredibly ill. So then they put me on Ibrutinib, which was fine for a few months, but then I got pneumonitis. I went on a trial for a Ibrutinib.
Yeah.
I got pneumonitis with that as well. But at the moment, I'm in a remission.
Yeah.
So they had worked a bit. Would venetoclax on its own work for me in the future?
Yes, I mean, it should, on balance of probability, it would still have a lot to offer you. It's a super drug. It works by a different mechanism to BTK inhibitors like Ibrutinib, and on its own, it's very effective. I mean, it's probably not long-term cure yet, and that's why the combination therapies of 2 or 3 drugs are looking so much more hopeful. But on its own, it's powerful.
I don't think I want to go back on Ibrutinib.
No. Ibrutinib does have side effects, no question about that. I mean, bleeding, bruising, atrial fibrillation, infections. I've seen quite a lot of immune suppression over time, patients on Ibrutinib. I mean, remember, it's killing your B cells, not just your tumour cells, but your B cells, and therefore antibody responses are significantly dampened. So what we really need is something that kills the tumour B cell, but not all your good B cells. So there's a lot of work to do.
If Ibrutinib was used to put you in remission to go to transplant, would you have access to Ibrutinib if you needed treatment further down the line?
Oh gosh, if needed further down the line, I'm sure that's a tricky one. I think it would depend on your local commissioning group in that time.
Because I noticed you said when you talked about Ibrutinib that in trials that where they had gaps that this could impact, and I didn't know whether, because you'd only had it for 6 months as an induction therapy, whether that meant that it would perhaps not be so successful second time round, or...
No. I think if it's worked for you for 6 months and you didn't lose the response to it and you just use it as a bridge to get to transplant, then I think it's very reasonable to go back on it. When I talked about breaks of therapy, I also perhaps should have just said, of course, sometimes you have to break therapy. If you're going to have an operation or a procedure like a colonoscopy or an endoscopy, you have to stop Ibrutinib for a few days because of the risk of bleeding. And what they say generally is if it's a big operation like a laparotomy, where you have an abdominal operation or someone's going to do something in your brain, you should stop it a week before and a week after. Whereas if it's something like a tooth coming out and you can put a finger on it, 3 days before, 3 days after. So don't be scared of stopping it for 2 weeks if you have to. But it's just to encourage compliance otherwise. Here's a question here. Do you give FCR if the patient is unmutated? I was talking about how FCR can cure maybe those 30%, how exciting that is. And we know that those are patients whose antibody gene in the tumour is mutated. So there is an argument that before you have FCR, you might want to ask your doctor to do a mutation test on your tumour. And if you are mutated, you'd be particularly keen to have FCR. Having said that, if you're unmutated, you probably still have FCR. So it's not something most centres do. But if you're very interested in your prognosis, then it is interesting. A question about pneumonia and fibrosis from Ibrutinib. I've not heard about that. All I would say is these are new agents and we're learning new things all the time. And even with Ibrutinib, we are getting some cases of rare infections like pneumocystis in the lungs. So we don't yet know what it's like to take out all your B cells for 6 years. Does chest X-rays carried out in the 50s subject people to high levels of radiation? Yeah, I mean, the CT scan is an interesting question. I did throw that in. I did think that would be quite a provocative question, but you've got to think about it. I'm actually not sure that perhaps doctors think enough about the high dose of X-rays. An abdominal CT is a lot of X-rays, and I do, we can use them quite liberally sometimes, unless it's going to change practice. You shouldn't do it lightly. Chest X-rays are very low X-ray dose. Chest X-rays very low, so I wouldn't worry about chest X-rays. Options for disease progression on Ibrutinib, I think it's venetoclax really. Would you believe that we actually have very generous permission for the use of these drugs in the UK? Venetoclax is very generous. We've got better access to venetoclax than in America. Because any progression from Ibrutinib, you can use venetoclax. That's not true in America, interestingly. That's interesting. When is the P53 gene tested? It should really be tested before any treatment. Having said that, I did have a patient recently, and they were going on to Ibrutinib because it was a relapsed disease. And I didn't have their P53 status, but it didn't really make any difference. I did it, they were negative, but whatever it would have been, they would have had Ibrutinib. So we should do it, but if you're on one of these new agents, it's going to work anyway, or it should do. Which area of the UK has the highest survival rate for CLL? That's quite an interesting question. There's no doubt about postcode responses to treatment. There's been a lot of concern about this. But, I would imagine, I don't have the data, that's probably more marked for more, things, solid tumours like breast cancer and ovarian cancer and esophageal, depending which surgeon you get to and which oncologist. I think that the treatment pathway for CLL is relatively clear. Asked how you may think not. But most haematologists should know what the right treatment is, and I would hope that we don't have a big postcode effect for this. And why does the watch and wait vary? Some people need treatment in a year, some people never need treatment. About half the people never need treatment. Well, that's all about two things, probably. I said I work on virus infections or bacterial infections. If somebody said, how important is a virus infection in somebody, there's two things you need to think about. You need to think about the virus and its sequence, and you need to think about the person, the host, and their capacity. I mean, the ability of all of us to respond to infection like flu is different, isn't it? We're all just slightly different. And therefore, when you think about CLL, what makes it progress? There's two things. There's your tumour, and all the genetic mutations that's acquired, different in every person. And then there's the host, you, how your immune system can cope with that. And so we're trying to understand and to learn from those factors about what makes people progress quickly and others not. We're learning some things, and Professor Stankovic will tell you at 2 o'clock, I think, about the genetics, but we're not there yet. But we will get there because the data is coming out very rapidly. Yeah. This is a question that people would ask me if I had an interview for a grant application. Why is the immune system and T cells ineffective at controlling cancer? Yeah. Well, I mean, we wish we knew. And it's a very important question for me because if somebody said, is there an immune response against skin cancer like melanoma or people who smoke a lot and get lung cancer, does the immune system try and kill it? Yes, definitely, no question. Somebody said, does the immune system try and kill chronic lymphocytic leukemia? It's harder to answer that. It's not so clear that there is a strong immune response against CLL. And we don't entirely know why. Very interesting question. Because the treatments, I talked to you about patients with lung cancer who are getting cured. They're getting cured because they're getting antibodies which boost their immune response and help the immune system to take back control. But when you do that in CLL, it's not proving as effective. So we could write theses on that, but we don't really know. And then finally, use and misuse of neuroimmunology on treatment and aftercare of CLL. Yeah, I mean, again, not particularly area of expertise for me, but there is a lot of unknown and unaddressed morbidity at living with the diagnosis and undergoing watch and wait. And there was a trial of early therapy in patients with CLL and low-grade lymphomas with rituximab alone. And they did find that there was a lot of improvement in psychological well-being with patients having early therapy. So, you know, it may be that as time goes on, when you have a lymphocyte count of 5 or 10, we'll come in with 3 drugs for 6 months and just cure it. And, you know, that might be the long-term control medically and psychologically. So that might be helpful as well. I think we're through the pile.
Yes, could you put your hands together and thank Paul?